Welcome to our program on medication-assisted treatment for opiate use disorder in North American indigenous communities. I'm Mehl-Madrona, and I'm with the Family Medicine Residency in Bangor, Maine, and with the University of Maine in Orono. And I'm also representing MAKWI, which I will tell you more about shortly. But and we want to acknowledge the Wabanaki people, the people of the Dawn, who are the native people here in Maine, and also thanks to SAMHSA for funding our project. So, and of course to all the members of the MAKWI team. So, Native Americans in Maine are quite rural and remote. Substance abuse is a problem for them as it is for all the populations of rural Maine. Medication-assisted treatment for opiate use disorder has only been available in Maine's major cities, often 2 to 4 hours driving distance from the reservations. MAKWI is a grant to provide support to Maine's tribes and tribal-related agencies to implement MAT. And MAKWI comes from a Penobscot word meaning together. The tribes of Maine consist of the Penobscot, two branches of the Passamaquoddy, the Maliseet, and the Mi'kmaq. So our goal was to be of service to the tribes in improving capacity for medication-assisted treatment. So, what do we provide? We provided site-specific consultation regarding implementation and maintenance of medication-assisted treatment, training in motivational interviewing, training in SBIRT, screening, brief intervention, and referral to treatment, community meetings and talking circles regarding MAT, naloxone, stigma, community relations, people's feelings about addictions and medication-assisted treatment, training in the use of naloxone, training in co-occurring disorders, training in indigenous approaches to promoting social and emotional well-being for this population, trainings in narrative medicine and suicide prevention, and ongoing consultation to sites MAT programs by faculty physicians from the residency. So 66% of people agreed that objectives were met, and 19% strongly agreed. Only 3% strongly disagreed, and 3% disagreed. So generally, people were happy with the trainings provided. Many things came out of the SBIRT and motivational interviewing trainings about things that people wanted to change about their practices, including looking for smaller signs of progress, being less rigid, being aware that alive constitutes success, using motivational interview more often to facilitate change, recognizing our own biases, learning how to better explain the program to clients, and watching and monitoring our own reactions to what people say. So more empathy, less judgment, better listening skills, and So we wanted to know what kinds of things did people want to learn further. And some of the things that came up included how to roll with resistance, how to work with teens who do not want to participate in services, learning more about methamphetamine addiction and its relation to opiate use disorders, helping families to better meet the needs of their children, dealing with stigma and trauma, and community awareness. And so this led us to develop a number of training programs, including trainings around meth addiction, positive parenting training, and trainings around working with trauma, indigenous approaches, and two-eyed seeing approaches to working with trauma. Generally, the trainings went very well, as one can see from this slide, and so we were able to increase the number of MAT programs available, the number of patients served, and the quality of those programs in consultation with the communities. So the naloxone training was also very important because overdoses are a problem in the communities, and distances to professional services are great. So it's very important that people have naloxone availability and capacity to use the naloxone. So so this was progressively more integrated into the care of patients who received narcotic prescriptions, and people in the communities were taught how to administer naloxone, and naloxone was made more widely available in the communities. So there are 5 communities five Native American communities in Maine that with which we worked, and also the Wabanaki Health and Wellness Center in Bangor, Maine, which is a center for urban Native Americans. And in fact, during the course of MAKWI, this particular center was able to get a medication-assisted treatment program off the ground and running with 30 patients. So they were able to go from 0 to 30 patients over the course of our involvement with them, which continues. So we looked at capacity in the various communities, presence of MDs, presence of FNPs, drug and alcohol counselors, LCSWs, nurses, CNAs, care coordinators, peer counselors or treatment coaches, and to look at the challenges that sites faced, which had to do with providers that come and go, dependence on locum providers, transportation looming large, stigma in the community being important, and to look at baseline clinic capacity and how we could improve that capacity. So as part of this process, we looked at how conventional counseling needed to be modified for this population. And I'll spend a little bit of time on that because that was one of the areas of my greatest concern. So we found quickly that talking circles were very important in terms of building group consensus and group cohesion, and moving the process along in terms of our discussions. Talking circles are common in Native American communities, and in a talking circle, obviously people sit in a circle, and a question is posed. Usually a talking stick, which is a sacred object, is passed around the circle, and people talk into the circle instead of at each other, and only the person holding the stick speaks and is never interrupted. And then the stick passes to the next person, and that person speaks and is never interrupted. And this became an important part of our consultation process and consensus building process. And another important idea that emerged was the idea that the substances which we ingest have spirit, and that when we take a substance without knowing its protocols, its songs and rituals, that it's a kind of sorcery, which no one wants to do. So that we have to work with the spirit of the substance. And a question that had powerful impact was, so do you know the protocols of the substance you're ingesting? Do you know the origins of the spirit that lives in that substances? Do you know what goes into the substance that you're taking? And including this as a part of motivational interviewing was quite effective. Storytelling and narrative were especially important because storytelling is central to Native American culture. Involving elders in the counseling process was important. And also, we were impressed with the importance of culture. Songs, language, prayers, ceremony, art. These things matter greatly, and increased acceptance and attendance in treatment. So talking to the spirit of the substance, to the spirit of the addiction, acknowledging the effect of the addiction on the entire community, and asking the question, who do you want to be the addict among your grandchildren? So if I'm an addict, then I'm going to pass this on to the next generation and to the next generation. And so my behavior impacts 7 generations forward. And so in 7 generations, who do you want to be the addict? And if you don't want anyone to be the addict in 7 generations, then it's up to you to stop being the addict today. So the importance, of course, community participation is crucial. So we offered training also in narrative medicine, narrative therapy, which is especially important in Native American communities, with the reliance on story and the power of story, and the notion that addiction is a story that we tell ourselves about who we are, and that we need a new story about ourselves as someone who's not an addict, who's not addicted anymore. So my 15 minutes will soon be over, and I invite you to dialogue with me at louis.mehl-madrona, no hyphen, at maine.edu. I'd be happy to discuss further any of the topics raised here.